Hi, it's Gary Chimes from Lake Washington Sports and Spine. I was asked by one of my physician colleagues if I could talk about the hip labrum. What is it? How do we diagnose it? How do we manage it? So let's first just even start more fundamental. What is a hip? So what a lot of people don't realize is that the hip, which we technically call the femoroacetabular joint, is a joint that's actually in the front of the groin as opposed to the outside or the buttock, although it can manifest that way. But it's unusual for people to have hip pathology without it manifesting in the front. So if we're going to draw that onto a diagram, you're going to have your thigh bone, which is your femur. I'll draw a truncated version of that. You're going to have what we call the femoral neck and then the femoral head. So that's going to be the femoral part of the femoroacetabular joint. And then you're going to have the socket, which is part of the pelvis. And that socket we specifically will call the acetabulum. For the purpose of the diagram, I'm making the space much wider than it actually is. Now, within that joint, you're going to have a hard, smooth cartilage on the end of the bone that's called hyaline cartilage. And that's going to be, from a structure standpoint, somewhat similar to like the Corningware or the Gorilla Glass that's used on the surface of an iPhone. And there's a second kind of cartilage, which is going to be your labrum. And your labrum is going to be on the socket side specifically. And it's a rubbery cartilage like your earlobe is a fiber cartilage. And I'm going to draw that in pink. And this is an imperfect diagram in the sense that it's making these things much larger than they actually appear. So why do you have a labrum? Well, the reason for the labrum, it's a mechanism for stability of the joint. So that if you think of it as almost like a toilet plunger where you have a rubber plunger that has liquid and then it adheres to the bottom of the bowl, that liquid in the vacuum creates a suction effect which provides stability. So that's the primary role of the labrum. And when we think about joint design, joints have this dual role of trying to be both stable and mobile. And the hip is an extreme example of an extraordinarily stable joint that does not have a lot of mobility. Its exact opposite would be the shoulder joint, where that's a very mobile joint, but not very stable. Now, the final thing that I haven't drawn in here is the capsule of the joint, and I'm going to draw that in a light blue. And that actually goes all the way out to the femoral neck. So when we talk about the hip joint, it actually isn't just the ball and socket, it actually extends out further. So when we think about hip pathology, I often distinguish between things that are intra-articular versus extra-articular. Intra-articular is going to be basically within that blue, and that could be the capsule itself, it can be the hyaline cartilage, or it can be the labrum. There's another structure called the ligament anterior that can be involved as well. Versus extra-articular, and those are going to be things like your gluteal muscles, or hip flexor tendons, or your SI joint in the back. Those are going to be extra-articular. Now, when people get labral pathology, it's often from a grinding effect, and that grinding effect can come for a few reasons, but probably the most important of those is going to be something called the femoroacetabular impingement. Again, femoroacetabular just refers to the joint. So when we talk about femoroacetabular impingement, one of the ways that you can think about it is that there's like this concavity within the neck of the femur, and then as you rotate, you need it to be able to clear this lip. So you can have an overgrowth from the acetabulum that's called a pincher mechanism. You can have a filling in of this concavity that's called a cam deformity, or you can have some combination. What happens is when you rotate that hip, it may predispose you to grinding. The other thing that can do that is like a tight capsule. So sometimes when I suspect that people have a femoroacetabular impingement or a labral tear, I'll order just what's called a standing AP pelvis X-ray, just to see is any of that constriction we're seeing related to bony anatomy. Because if it is, you want to be careful about like overly grinding it. You don't want to get too aggressive in range of motion exercises to the point where you tear through the labrum. Mobility of the hip is also something that's like super duper boring. It's really slow. You want to be careful not to be too aggressive about it. You're often doing repetitive motion over time. And when we think about mobility programs for the hip, really the dominant thing you need to do is focus on how frequently you do it rather than how intensely or how long you do it for. So those are some of the things you might think about from like a mobility standpoint, and that's something you might do with a rehabilitative professional like a physical therapist or a chiropractor. Now, to actually see the labrum itself, that's something you're not going to see on an X-ray, and you might not see it on a regular MRI either. You may have to do what's called an MR arthrogram, where they inject contrast into the joint capsule to see to expand it open. The reason that's important is, let's say like your labrum is torn, Because it's right up against the femoral head, you might miss it. So you need to create some space so that tear can float. The other thing that can be useful when you do an MR arthrogram, and I always recommend they put like a numbing agent into the joint because that helps it, confirm. Like, let's say you find a labral tear, it may not actually be painful. So for me, what's really useful is an MR arthrogram confirming the tear and also confirming relief of the symptoms that are associated with the numbing agent being placed into the joint. Now, let's say that we have somebody who has a confirmed tear. One of the options that exists is surgery, and they have different kinds of surgeries, like surgical repairs of the labrum, and they can also do a reshaping or resurfacing surgery to try to address some of the underlying femoroacetabular impingement. It's an okay surgery. It's not a surgery that has like a super high, spectacular success rate. It's also not a surgery that fails all the time. But as a general rule, I think it's something where it wouldn't be my first choice. There's some surgeries like a carpal tunnel release that, they're so successful that you might as well just do it. But I don't think that that's necessarily the case for labral repairs. Are some other intermediaries, as we talked about, working with a rehabilitative professional. Sometimes what we can do is something called an ultrasound-guided hydrodilation. One important point is whenever you're injecting the joint of the hip in particular, you really need to make sure you're doing it under ultrasound guidance so you can really see the needle go into the space. There's things you don't want to hit like the femoral artery and the femoral nerves, so you really need to make sure you're seeing what you're injecting. And the idea behind a hydrodilation is you just fill up the joint with as much fluid as you can to see if you can get some additional mobility. Historically, people have used cortisone. I'm not a big fan of using cortisone anymore for hip labral injuries. It may give you some short-term benefit, but it really tends to lead to more progression and degeneration of the labrum. I will use it in some special circumstances, like if somebody has a high leverage trip, like they're going to be going to New Zealand for 2 months, and it's a once in a lifetime trip, and they're willing to have more degeneration down the road to feel better on that trip. Maybe that's a circumstance where cortisone makes sense. But in general, I would prefer not to do that. I think where we've moved is towards using orthobiologic treatments. We sometimes use micronized fat, probably most commonly use platelet-rich plasma. And what that does is it really helps improve the health of the tissue. Now, some people say, well, is it really like fully repairing it? And not necessarily. The way I think about it is if you have a normal labrum, which is supposed to be like this, and then you have a tear where you have some jagged edge. It's almost like if you have like a cuticle that is kind of fraying, and if you can just kind of clean up the edge so that leading edge is not as raw, that probably is part of why platelet-rich plasma works. We do know that does seem to really make a difference, probably for about 70 to 80% of patients, and it's a really nice intermediate that we have available. So those are some of my thoughts about the labrum, and if you have any questions, feel free to see us as a patient, either myself or my partner, Dr. Hyman, at Lake Washington Sports and Spine. Thanks.